Welcome to the Special Operations Medical Association podcast series on prolonged field care. Any opinions contained in these podcasts are those of the authors alone and do not reflect U.S. Army, DoD, or U.S. government opinion or policy.
All right, welcome back to the PFC podcast. Today we're going to talk about telemedicine. So the working group has been looking at PFC for about a year now. And at this point, we can probably break PFC down into three essential components: point of injury care, evacuation, and telemedicine. If you're not solid on any one of these components, you're probably going to have a bad day. And I get it, certain mission sets aren't going to allow for the standard degree of each of those components. However, they're always available in some form or fashion for every mission set. So by point of injury care, we're referring to those 10 core competencies or activities of PFC. By evacuation, we're mostly talking about understanding your evacuation system and having a good primary, alternate, contingency, and emergency plan for getting your patient moved out of theater. Telemedicine is your link from the patient all the way to the receiving facility. So one of our objectives in doing this podcast is to emphasize the who instead of the how for telemedicine. It seems like people are focusing a lot of energy and effort onto the what or the how for teleconsultation. What sort of technology are we using to make a phone call instead of worrying about who's on the other end of the phone? I got it. There's some great pieces of kit out there. The Tempus is a really neat device, and there's competitors coming on the market. But at the end of the day, if all you have is a sat phone or a cell phone that gets you in contact with the receiving facility's trauma team, then we would call that a successful telemedicine consult. So instead of focusing on technology, the PFC working group is focusing on the actual call that needs to be made and the procedure for making those calls, and to give you, the listener, a cheat sheet and some lessons learned from consultations that have happened in the past. In talking about telemedicine, the OPSEC thing comes up every time, so let's just address that right up front. This has a lot to do with assumption of risk. If one of your brethren is sitting in front of you in critical condition at a remote setting and OPSEC is a concern, then that's a risk that needs to be weighed. But it's our opinion that in the grand scheme of things, the risk to that patient's life is going to outweigh the risk incurred by a potential OPSEC spike. And let's face it, 99% of the missions going on out there aren't going to require that level of OPSEC, where you would let a critical patient suffer in the name of OPSEC. One of the huge benefits of teleconsultation that I think goes unnoticed is the fact that once you engage a team of experts on the other end of the phone while you're in the midst of a crisis, that's going to take a huge amount of stress off of your shoulders. Just the ability to talk through the situation on the ground, get some advice, and in some cases, pass off some of those difficult decisions to a team who does this for a living every day in a major facility. We should also note that we're not saying that the only phone call that you make is to a teleconsultation physician. We're saying that there's about 10 different phone calls that need to be made all at the same time. In fact, along with this podcast on the website, we're posting a sample execution checklist that we came up with of just, chalk talking how this thing might go down, all the different phone calls that are going to need to be made, and to give you an example of how you could task organize that as to who's calling who, and who's calling the team to let everybody know, who's calling the embassy, who's calling the TSOC, and who's calling the home unit. If you're in the midst of a crisis and you've got a difficult patient on your hands, you're not going to have time to make those phone calls. The only phone call that you're going to be able to handle really is the consultation call to the receiving facility. So if you go to prolongedfieldcare.org, check out the products that come with this podcast. You're going to see one of those is an execution checklist. Another issue we want to help you tackle is clarity in your consultation call. We're going to post a few items on the webpage to hopefully assist you. But we want to emphasize too that this should be a clinical presentation conversation that you're having with the receiving physician, and we recommend you steer clear of an EMS style run report where you just dump a whole bunch of information on somebody. We've found that in testing these phone calls out, it's best to have a conversation just like you were presenting a patient in the clinic. And, the SOAP format might work well, subjective, objective assessment in your plan, but really we don't want to be too cumbersome with it. So it doesn't have to be a massive review of system or a systems-based presentation of the patient. But the feedback we've gotten from physicians on the other end of the phone is that they want to know what you see, what happened, and they want to know what you think is wrong. They want your master problem list and what you think needs to be done about it. They want to know what concerns you so they can help you war game through some of the potential complications that might arise over the next 24 or 48 hours. Since there are a number of potential complications that could arise in a prolonged field care setting, it's important that part of your telemedicine call is developing a master problem list. For example, supposing you're treating a patient after getting into a car wreck in a third world country overseas, and you're not going to be able to get him out for a day or two. He hit his head, he's got belly pain, so you've got this potential closed head injury. He might be bleeding in his belly. So there's a couple different things he's got going on that you're going to need to potentially work through. So this is your opportunity on the telemedicine call, not just to give the physician a bunch of data, but to talk through these problems with him before you hang up the phone and come up with a plan that he's good with as the receiving physician. This is a good example of why your telemedicine plan can't be calling back to your home units, doctor or PA. You want to be talking to the receiving facility who's got a trauma team on call in scrubs, there to do medicine at that very moment. And yeah, you might be calling those guys at 2 a.m, but this is their job. This is what they're there for. And they're going to have a lot of buy-in with that patient because they're going to be receiving him probably in the next day or two. This is way different from most commercial telemedicine services out there that patch you through to a major university emergency room. Your patient isn't going to end up at that facility. So you might be talking to a great physician, but at the end of the day, it's not really his patient. It's not coming to his facility. So in the military, we have the luxury of working out these comm systems. And I don't think we'd be flooding one of these facilities like Launchstool or Tripler or BAMC with a whole bunch of phone calls all the time. I think this would be a very rare occurrence, but it's important to have the right phone numbers to get in contact with the trauma attending. I don't, however, think it's your job to go seek out that phone number on your own. I think that that's a TSOC function. I think that's something you can rely on the TSOC for, especially when you're doing all your pre-deployment workup stuff. All right, so in addition to that execution checklist that we're posting on prolongedfieldcare.org, we're also going to compile all the different casualty cards that we've received as recommendations and post them on there. We've gotten a lot of requests to come up with a card, and it's really hard to come up with something that everyone's going to be happy with, as well as something that's going to work for every kind of mission that's out there. And the reason I'm bringing up casualty cards right now is because this is a critical component of your telemedicine consultation. So whatever you're going to put together is on you, but there's a few key principles just to keep in mind. Number one is don't forget the basic patient information that every consulting physician is going to want to know right up front, such as patient age, weight, allergies, past medical and surgical history, all the stuff that goes into a regular patient note. But don't overlook that stuff because that's going to be relevant to all the specialists that are going to be weighing in on that patient. Next would be a spot where you come up with a real short, clear, concise narrative of what the mechanism of injury was and what happened to the patient, so that when you do have these phone calls, you don't have to fumble through a lengthy response with too many details, so that you just have a real clear way of explaining what happened to the patient. This is also where your master problem list comes in really handy, so that anytime you talk to a new doc or anytime you want to review the patient with a consulting physician over the course of the prolonged field care event, you're going to be able to go down the list of all the things that are concerning you and what your plan is if one of those things happens. And then the next requirement would be somewhere to trend out your vital signs over the course of hours. So one of the cards we threw on there has 2 pages of the same log so that you can just continuously monitor these vital signs. And then at a glance, you'll be able to see how the vital signs are trending out. And even if you have a Tempus or something like that, where you can broadcast real-time vitals, it helps you to just get a snapshot picture of how the patient's doing. And that's just standard anesthesia practice. So what we're doing is we're just adopting a known TTP and then adding it into this card. And then lastly, you're going to see a whole bunch of examples of cheat sheets that people add onto the card. We put one on there of just different nursing care things. The Canadians came up with a great card that uses Hitman as their prolonged field care acronym that runs them through all the different steps they're going to need to take or consider. We threw a GCS thing on there, so that way you're not just taking a GCS on a head injured patient. You're actually able to trend it out over time so that you can see what all the subtle little changes are and explain it to a consulting physician. So once you take a look at all the cards that are out there and you decide that you want something out of each of those different cards that'll work for you, all you have to do is just open up a new PowerPoint, drag all the pieces into your PowerPoint that you want, print the thing out, and then laminate it, and you got yourself a casualty card. All right, so next up, we're going to hear from Doc Keenan, who's an ER doc. All right, so now we're going to hear from Dr. Sean Keenan. As the head of the Prolonged Field Care Working Group, this whole concept of telemedicine comes across his desk all the time. People have all kinds of issues that they want to address. But in addition to being the head of the working group, Sean's also an ER doc. So his perspective on telemedicine is pretty unique. He's got a lot of experience receiving phone calls from the field, as well as placing teleconsultation calls up to different specialists.
The first thing you have to realize is that these aren't routine medevacs. This is going to be a low frequency but highly critical patient evacuation. But also, as soon as you activate the chain, most of the people in the operational chain are going to be focusing over on it becomes an operational problem. The good news is you're going to probably get a lot of resources focused on your problem. But the bad news is you're still out there holding on to the patient. So you may be flying in a CCAT team, but that CCAT team may not be there for 8 or 12 or 24 or 36 hours. As we're realizing, one thing we don't think about in the operational problem is that we have freedom of movement, or had it, in Iraq and in Afghanistan right now. But when you're going to another country, you actually need to apply for country clearance. You need to get the Department of State involved. There's a lot of operational things that happen behind the scene. And so this isn't only about taking care of a critical patient. This is an operational problem that has to deal with a lot of different resources and air evac and things like that. But one thing that we talked about is in exercising is the communications piece of this whole thing. So the way that that's all going to start is if you call and you ask for that. And it seems like an obvious statement, but a lot of times people are thinking, okay, I'm the medic, I'm taking care of this guy in a vacuum. Like you're not going to have help there. But the thing that we talk about as an emergency physician, when I'm working, an 8 or 10 hour shift in the emergency department, whenever I have a question or I need help with somebody, the natural thing to do is to consult, to call up somebody. I'll say, somebody smarter than me or at least more experienced than me in whatever subject matter. And the normal way that we do business in American medicine is as soon as I get outside whatever my training is, I'm calling somebody. I'm calling somebody for advice. I'm calling somebody because they need a surgery. I'm calling somebody because they need to come into the hospital. But the normal thing is that I am collaborating and sharing my medical decision making. And yet there's this culture out there in special operations is that the medic has got it covered, and somehow calling or talking to somebody is a sign of weakness. And I think we need to get over that right now and understand that if we practice medicine in a regular hospital all the time by calling other people, then it should absolutely be expected that they should call for advice, call for help, call for whatever they need. And there's an art to that calling. There is a format that we use. There's a way to practice that, and our guys need to be trained in how to call. We even talked about, for instance, if you're calling 9-line medevac, you've got medevac, the format posted right there on the radio, and you're just filling in the blanks so that your commo guy can call or something like that. Well, we need to train guys in how to make a consult and how to get that information across. And so calling, we got to have a cultural shift to say, hey, call early, call often, call for help, call for whatever you need. But we need to train guys to be able to do that. And that's not something that is ingrained in the culture, because some people think that calling is going to be a sign of weakness or calling is going to expose that you don't know something. But at the end of the day, we're talking about sick patients, and these are not protocolized trauma patients. These are people that might have all kinds of crazy stuff going on. They might be going into ARDS, where their lungs are filling with fluid. They might be going into sepsis, where they're having overwhelming infection. They may be going into renal failure. And these guys are people that I would naturally call on. We need to train our guys that they need to be able to call for help. And that's part of, exercising this is doing that. And then the backside, we need to have somebody reliable to call. And so, we're dealing with that. And that's more of a operational, a TSOC level function. But on the other side, on the operations planning, we got to have somebody to call. It's not your patient or your guy, it's our patient. When you're bringing that person in, now you've created a team. The guy might not be there with you, but and especially if it's going to a referral center like Launchstool, they got buy-in because that's going to be their patient in 12 hours. They're going to start telling you to do stuff. But there is an art to communicating that, and I realize some guys are like, oh, they're going to think I'm a dumbass. Well, no, they're going to think you're a dumbass if you don't call. Maybe flailing a little bit more where you could get some direction. But I think it's expected, and guys are used to being called every single day for this type of stuff. So it's a normal practice, and guys just got to get, into that mindset of saying, hey, recognizing they're getting in over their head or recognizing they need help. And even if that help is just in the form of, get me a medevac, get me some transportation, but they need to call, they need to practice calling, and they need to call early when they first start thinking about it. What you need to do is figure out what you need. So if you call up somebody at 2 a.m, and you start going, I got a 21-year-old guy, and and he started feeling sick a couple days ago, and then his belly hurts, and then he started throwing up, and then he had some diarrhea, but I don't think the diarrhea, I think it was a throwing up. And then when I push on his belly, it kind of hurts on the right side, and you go down this big long thing, and at the end of the day, the guy's half asleep that you're calling, and he's like, well, what do you need me to do? But what you should do is you need to figure out what you want from that person, and you need to state it right up front. So we actually made kind of a draft sheet, which basically says, this is Medic Smith. I'm sitting in the middle of nowhere, Africa. I have a 21-year-old guy that's had belly pain for 2 days. I think he has appendicitis, and I need a flight out. I need a surgeon. I need information about what antibiotic I should give to that guy. Then you go into a little bit of a history and physical. You can go into that. Always start with vital signs. Get a complete set of vital signs right up front. Say, everything's normal except for his belly exam. He's tender with rebound tenderness in his right lower quadrant. And then finish that with restating what you need. I need a plane out of here. And if you follow that, a guy immediately perks up. So you tell him right up front what you need, then you get into the details, you just finish it up with what they need. And then that should be enough for your consultant to recommend whatever it is that they recommend. Telemedicine in its purest form is just getting a reliable phone number that you can make commo on and getting some useful information from the other side. To a certain extent, the medic on the ground needs to drive the conversation. They need to decide why they're calling in the first place. And it sounds like an obvious statement, but it goes back to that script. This is me, this is where I'm at, this is what I got, and I need. And that's going to drive the conversation. If you get that right up front, the guy on the other end of the line is going to start tuning in. And then if for some reason he's just not getting it and say, no, look, I'm in Africa, and by the way, this is going to be your patient in 12 or 24 hours, that immediately puts skin in the game and gets buy-in from that guy on the other end. And there may be some communication difficulties, but that person's going to want to know sooner rather than later, hey, I've got a patient coming my way, so I can start prepping for that. And the vast majority of folks, the great thing about medicine, the great reason that, the working group works so well is, there's this collegial atmosphere with people talking about stuff. And it's not about, I can't talk to this guy because it's an operational risk, or I can't talk to him because he's a surgical subspecialist and I'm only a medic. No, when you're all caring for a patient, people rally around that pretty quickly. And it's just a matter of you effectively and clearly communicating what you need. And I think you're going to find that a lot of people are going to rally around to help you out with that, even if they are remote, even if they're not going to see this person. So, again, culture change, getting over the hump of saying, look, I'm starting to get in over my head and making that call early. And the other thing, too, is the way we affect that culture change is by calling early and often. So if a guy's downrange, call him up, try him out. Start talking to these guys. Get them used to talking to you so that the first time you don't talk to this person is when you're knee-deep in it and you've got a critical patient and you need some stuff. But if you've already talked to this person once or twice before, if you've exercised this, then that is going to be crucial to exercising it and to training the consultants on the other end of the line as to who they're talking to and what that situation is. I'm an emergency physician. I make decisions all the time, but I'm still calling people all the time because, two brains are smarter than one. And if I need help and I realize what my limitations are, I know I'm going to call. And sometimes I'll call within 2 minutes of starting to see a patient. And sometimes I'll wait 4 hours before I make a call. And it just depends on that. But there are times where I will call immediately because I realize it's either not my lane or I need help or something like that. And, maybe, my ego is pretty small and I'm acutely aware of what I don't know. But guys need to understand that is common practice in American medicine to call. Do that.
All right. Thanks for listening. Please send all your comments to prolongedfieldcare.org and go ahead and check out the products that are posted up there.